Graham?
Thanks very much for that introduction, Nabil, and thanks again for having us tonight. It's really great to be here. And like you mentioned, both Dr. Costa and I have offices kind of across the street from the terminal buildings at this campus here in downtown Kitchener, and it's actually been one of the strengths of our team to be able to have such great neighbors, and to be able to collaborate with places like Terminal. So let me just actually start out again by maybe I'll back it up here and just kind of talk a little bit about who we are, and then and then we can kind of go from there. But like Nabil mentioned, we mainly work as the big data and geriatrics models of care research group. We also have that leads us into doing a lot of kind of educational stuff, a lot of research. We're based all over the province, all over the country, and we have quite a few members of our team all over the world. So I think that's another really interesting connection that we have, kind of being in the terminal space, and having a team where doing things like remote work is such an important way to leverage things for us. But anyway, without any further rambling on my part, let's bring in Dr. Andrew Costa. He's our fearless leader, and you know what? Maybe actually, Andrew, I'll instead of rambling on about your titles, I'll let you give us like a lowdown on who you are and what you do.
Yeah, sure. Thanks, Graham, and thanks to Terminal for having us in this private/public conversation. A lot of fun to talk to you, Graham, because now that with all the COVID happenings, et cetera, we're not in the same office a lot. Not that we were tremendously a lot, but this gives us the opportunity to chat about research stuff, in a more long form way. So it's fun. I'm assistant professor in the School of Medicine at McMaster University in the Department of Health Research Methods, Evidence, and Impact. And basically, the department is kind of a historically important department. It was founded by somebody who founded the concepts around evidence-based medicine, David Sackett, and who then went on to Oxford University. So we're proud of that heritage. In addition to that, I have a few hats that I wear that are, in the end, as you know, Graham, all come in at the same place, which is usually around data, older adults, and health systems. And that's the cycle chair in clinical epidemiology and biostatistics, the research director at the School of Medicine, Waterloo Regional Campus, which is situated in Kitchener-Waterloo, our Silicon Valley North, I think, as we refer to it. Great tech community with Terminal. We're part of a wonderful group there that we get to work with, and we're lucky to be able to work with. And then I'm the research director at the St. Joseph's Healthcare Center for Integrated Care, which is just a short drive in Hamilton. And it all kind of mixes in. It's about data, it's about seniors and older adults, and we point our efforts to various systems, long-term care, home care, hospitals, and have a lot of fun doing it.
Yeah, that's interesting. And I know that, this kind of actually maybe leads us into... What's that?
I said it is fun, right?
It is fun. Yeah. You know what? Just because we're on the air here with a couple hundred people. No, you know what? It is. It's great. And it's one of the things actually that I think, if I can just start rambling right away, that is so great about kind of being able to work down here in this area, in this space is, like you mentioned, we do a lot of stuff around older adults. We do a lot of stuff around different models of care. And we do a lot of stuff around, using data and using education to try and help out different public health situations. So, being in this location at this campus, in this kind of like Silicon Valley North, like you were saying, has been a really interesting place because it's led to a lot of these really cool collaborations. Like the fact that that I'm sitting here in the terminal offices right now, using their very stable internet connection to talk to you here. So it's been fantastic, and actually, it kind of brings me to I guess maybe my first 2 points. Uh, Firstly, I think we're going to establish right away that what we're going to refer to each other as. I might have a problem with calling you Dr. Costa or remembering to do that
Yeah,
for an
because you
hour.
always do, right?
Right, exactly.
No.
Um, so I think maybe that kind of speaks to the informal or the conversational kind of tone that I hope this can have. So
Yes,
yeah.
please.
So in saying that, yeah, and now I'm addressing kind of the folks watching. Like Nabil mentioned, we are happy to engage with questions and to talk about some stuff. If we're not experts in that subject area, we'll be the first to tell you. But I think we can have some fun and talk about these things regardless. So um, yeah, you know what, Andrew? Speaking of kind of the what you were just kind of mentioning about all those different hats you wear, that's a bunch of different campuses. It's a bunch of different hospitals, a bunch of different buildings. Obviously, we're in a time right now where a lot of those things are closed down. A lot of those folks are working from home, and a lot of universities and academic centers are working from home too. But we're in a spot where research has to go on, innovation has to go on. We have to kind of continue to solve problems. But how are you seeing that happen right now with a lot of these closures, especially with all those hats you wear?
Yeah, so it's been an interesting trip. I mean, I came back from an overseas trip, hearing the news around COVID, and my wife, who's a nurse practitioner, was sort of following the news a bit more closely with a bit more concern. She was with us, and we had a bit of a family trip associated with it. And I was sort of thinking, oh, this is just another thing. Who knows? I wasn't paying attention, mind you. And when we came home, coming through France, that's when, just basically behind our footsteps is when the pandemic was really taking shape. And so I came back, and within that first week, it went from business as usual to the campus being closed. And so at McMaster University, we're one of the most research-intensive health sciences universities in Canada and indeed in the world. And it's anyone's guess as to how long this will last. And it's changed things for the foreseeable future. So we're currently closed. Our academic hospitals are operating on a very different kind of capacity. For the universities, it's meant that classes are canceled. It's meant that our research facilities are more or less closed, except for those that are of a critical nature. Biorepositories, freezers need to be kept cold, and these sorts of things. But we're slowly making our way back into phase one for people that had experiments and have lab work to do. They're going to get in a bit sooner than folks like us who do more data work, can work from home. I don't anticipate that we'll be going back anytime soon. Our hospitals are,
Sure.
They're very different places now. We ramped up, like many hospitals in North America and around the world, for a big influx of COVID-19 patients. That hasn't materialized. I think we've done our job around social distancing, as many places have. And in fact, we've got sort of the opposite situation where, there's crickets in our hospital wards and our emergency departments. And the big fear, and it's actually true, we're seeing data, is that a lot of people are withholding going to the emergency department, and we're seeing an increase in rates of heart attacks, et cetera, for diseases that are left uncontrolled because people aren't really coming in as they usually would. It's changed everything.
Yeah, it sounds like it's something that's like you say, it's a different playing field, right? We hear a lot of people talk now about kind of new normals and things like that. So it sounds like it's something that we're just kind of negotiating on an ongoing basis. I wanted to actually jump back to something that you had mentioned there about some of the work that the group does. I think it might be a little bit helpful, maybe we can dive into some of that stuff a little bit more specifically later, but maybe it's something helpful. We've been talking a little bit about big data and kind of, how that works. But if we can back up for a second, I know it took me, it took me a little bit to understand what that actually means. So can we take a pause for a second, and can you just kind of give me a little explanation, like I'm, explain like I'm five, kind of, what is this? What is this capital B, capital D, big data that that we work with?
Yeah, and so big data's got some pretty known definitions. Usually, it's described by these 3 or 4 V concepts, and it's a useful way of thinking about it. It's big data is sort of a phenomenon, and so it defies a little bit of definition. It's basically a reality of our digital existence, and it's a byproduct of it, as well as sort of continues to shape it. And when you think of big data, you think of number one, volume, just a lot of information, a lot of zeros and ones flowing, because we have digital systems, devices that just basically in our healthcare system, which I'll focus on, but really in everything else, they create data as a byproduct. And so we're seeing more and more of that. It's cheaper to store that data, to host that data. We're getting better tools to analyze those data. And so, volume is a big thing. What's also, very good is, in depth defining it, is the velocity of the data. So not only do we have big sources of data, but they're keep streaming in faster and faster. We have more real-time data sources, which gives us a lot more possibilities. I know we'll discuss that with respect to COVID and how we are or not tapping those data. Then variety, yeah. We have a lot of types of data. We have structured data, things that we can analyze pretty easily. Unstructured data like text mining in healthcare, that's a lot. It's really common to our frustration around the fact that physicians, nurses, everyone likes to chart using their notes. And it's very hard there's so much knowledge there, so much investment there. It's hard to pull that out. So that's sort of the challenge and the opportunity around variety. And then veracity. Anybody who uses large data sources always has to consider, how good is this data? What is it telling us? Is it biased? Is it even useful? And that's always an ongoing conversation, because there's a big sort of like a loss function on all the data that's created, even though we're storing it for a day when hopefully it'll come to good use. So that's big data, right. But essentially it's kind of it's big compared to what we used to have. That's big data.
Right. So you mentioned a couple things about that. Actually, I'd kind of like to pick up on, given like the space that we're in right now. I know that our team does a lot of work with, and you specifically, Andrew, do a lot of work with folks like developers, with folks that are data architects, and design that kind of infrastructure. Obviously we use all of this data in the healthcare system. Do you think maybe we can kind of talk about some of the challenges or some of the opportunities that present itself in this, and that we can then kind of look at how we end up predicting things like this, and how we try and make these models?
Yeah, and so our big, from the perspective of someone that works in healthcare systems, we're using a lot of secondary data that's created by health systems, EMR systems, hospitals, et cetera. And those are sort of common type data, like anytime that someone enters something in a chart, clicks a box, data are abstracted from that, either electronic, more or less electronically. As we get better, the biggest challenge and the biggest opportunity emerging is basically having EMR systems that are more digital. Many systems remain basically glorified PDFs, or if you look into a medical chart, it's still quite common that what you see is essentially like a bank of 40 PDF pages. That's changing though pretty rapidly, and even around the margins of that, we have pretty good big data where we understand diagnostic patterns, admission patterns on a more of a meta level, which is what we call a metadata. And from that, we can understand a lot about health behaviors, health systems, do a lot of prediction algorithms. And so we've got, those are our sort of common sources of data. There's emerging very interesting sources of data that's flipping everything in healthcare analytics, and will continue to. Basically, it used to be that all of the data that we had about healthcare systems was in the system itself. It was owned by hospitals, owned by health systems providers. That's changing pretty rapidly with the advent of health apps, in-home technologies. People are more and more able to get track their own health, control their own health data, contribute to their own health data like their Fitbits and et cetera. And increasingly, they're able to do pretty sophisticated diagnostics that were only possible in emergency departments in hospitals. They're able to do that in their home by themselves because the cost function for those devices and storing them has come down just tremendously. Kind of like the same impact as like cell phones with the computing revolution. It's those devices and systems associated are bringing that to healthcare. So we're rapidly moving towards a future where someone like me that accesses health data to create tools for providers, doctors, nurses, increasingly we're going to be creating it more for people. And where it used to be that your doctor or your hospital had your health information, maybe you could get a hold of it, maybe you couldn't. Increasingly, it's going to be more people having more information than their physicians, than the hospital they're in. And it'll be up to them to be able to share it with their healthcare providers, maybe more than one, which will really shift the power dynamics. So we're moving pretty quickly to that future.
Yeah, it seems like a case where, we're almost living in the future. So in that case, if we have all this data, if we have everyone's, app data, this kind of thing, where does the difficulty come in predicting super rare events like this? Where do we, how do we make these predictions in this case when we're talking about, things more specifically like COVID?
Well, I mean, like if we go into COVID, and I guess let's dive right in. If we don't know, I guess it's important to say that there's a lot that's unknown about COVID because it is still so new. Not only is it a new disease that we don't know a lot about, but how it spreads through community and the various people that are involved in helping to research that, it's sort of a new phenomenon. It's been an amazing thing to witness in the world where a lot of researchers who weren't infectious disease researchers are pointing themselves towards COVID and trying to produce things that are useful in either helping to prevent outbreaks or to manage outbreaks in patient populations. And it's been amazing to witness. We're a good example of that. In our team, we haven't done infectious disease research it's not in our history. Typically what we do is we look at transition patterns among patients and we try and predict outcomes like future hospitalizations. So the stuff that we traditionally have done is we create algorithms that become part of EMR systems that help clinicians make decisions about individual patient cases. Right. And so we're using data on everybody to help make decisions on particular individuals. And we use these large sources of data on people's health to make those decisions. And we use some pretty routine methods, and we use some more fancier machine learning methods, bridging towards artificial intelligence. And we're pointing ourselves towards COVID because ground zero in the fight against COVID and the influences of COVID has been towards older adults. Pretty much amongst the most vulnerable in our society. And for us who do work in care of older adults, it's a responsibility that we've collectively, all of us, I think, in the field have taken on to try and join the effort. And so we've done a couple of important things towards that effort ourselves. It's tough. Why, from a data perspective, why is COVID a difficult thing to track? Like we've seen that. That's actually.
Yeah, sorry. I'm just going to say that's kind of what I'm wondering is can you speak to that a little bit? Like, why is it such a difficult situation to understand? That I think that's kind of a very interesting question.
Part of it is how it's played out. So when the pandemic first started, there was projections around death rates and need for ventilators and so forth, and those projections have largely overshot the reality. And it's no surprise because, as Yogi Berra said, it's difficult to make predictions, especially about the future. And in science, we're typically not very good at it. And that's because we're in all those predictions, you're trying to predict human behavior, and it's just a very difficult concept. Because as soon as you predict something and that is known, let's say in this case, COVID being a looming crisis to moving through countries, then immediately society and people react with that knowledge, which changes the underlying dynamics that you had built in your model. And so it's kind of like playing a sport. We say in Canada, you don't move where the puck is, you move where the puck's going to be. And
Right.
maybe it's hard enough to do in hockey. It's very difficult to do in science and in population health. And that's continued to get harder. So one thing to know about COVID, I think probably, I mean, for us, the most single important thing is that it is a local phenomenon at a global scale. And what I mean by that is that because we've been largely very good at social distancing, really across countries, that very, very positive occurrence has made science and COVID more and more challenging. And what I mean by that is that there's a lot of noise in the associated data. Give you an example. You can look at, so in the evidence, we have a lot of case series data from heavily affected countries in Europe and in Asia. And what we note is that we're not seeing the same sort of phenomenon that they're seeing in their countries. Now, on a crude basis, we are. Those that are sicker, more comorbidities, older, are more likely to be vulnerable to developing serious disease and death. But at a more granular level, those data don't really match what we're seeing in terms of the people that are being hospitalized in our regions. And so we're not seeing sort of the same flow. So the local situation is different from region to region, is what we're realizing, where we're seeing longer length of stay in some regions versus others, younger people being admitted versus older people. And that's because it's actually a rare event. We don't know if it's a rare event to basically be infected by the SARS-CoV-2 infection. But we know that it's a fairly rare event that someone develops enough symptoms that they're hospitalized, and that's usually when we tend to see cases. And so it's a rare event. It's essentially rare events or stochastic modeling, meaning you're modeling a lot of noise and not a lot of signal. If we had a huge outbreak, we would know a lot more about the disease spread because we would have a much larger sample to do analytics on. Right now, we have very few. Give an example. We have in our hospitals at the moment surrounding us, census of about 60 patients in very large academic hospitals, which is not a lot. And so it's very difficult to generate knowledge on 60 cases per hospital. And it's also very difficult to, if you boil up those data at a country level or state level or provincial level, it's difficult to actually translate that learning into local health study they're seeing is so different because to get sick is almost like a chance occurrence. It's by definition very difficult to predict because we're doing pretty well at social isolation. So that's the challenge, and in our region in Kitchener, where we have a lot of tech companies, as you said, we have a population of about 500,000, and in our region we've had something like just over 200 hospitalized.
Right.
And in and of itself, that's about 4 times what surrounding regions have had. So in Kitchener, where we live, we have 4 times the rate. It's not at all clear as to why that is the case. Not at all. And it wasn't like we had a big festival and the surrounding communities did not. And so we're seeing more cases, we're seeing different cases, and we have no idea why.
Interesting. I mean, interesting and terrifying. But in that case, what do we do from that point then in terms of tracking? Is this something, like how can we navigate some of these challenges? Is this something where we can do some public health tracing? What about some of the the resources that your team, our team, has been developing around this as kind of a response using big data to shape some of our responses.
It's meant that we've had to collaborate a lot, and so as you know, Graham, in our region or our surrounding regions, we live. If folks are familiar with Toronto, we live south of Toronto in a very, very busy region of southern Ontario that basically surrounds a very large lake called Lake Ontario. And it goes essentially from sort of like Toronto all the way to Niagara Falls towards the US border. And in this, few regions, we have about 2 million individuals living. And so we've had to collaborate with across the regions to be able to pool data in order to have the data resource to be able to do the analytics and create tools to make decisions about the spread of the disease, as well as how we're managing those who get sick. An example of that is we created the Courage Registry. So it's a coronavirus registry of all admitted patients who are confirmed with COVID and all individuals who go through a hospital's emergency department with mild symptoms and are identified either afterwards or during as having COVID, but were discharged home. And so what we're doing across those hospital systems is capturing all of those cases and pooling it. And we're working with so that's an example of pooling at a regional level so that we have enough information. We're collecting very detailed things from the charts, like onset history, all the admitting labs, daily lab information, pathogen testing, symptoms, comorbidities, really everything that you could possibly get. And a group parallel to us is actually collecting all the biospecimens from those patients and creating a biobank. And we'll link the data afterwards.
So this is
the data that we're collecting. No worries. I'll just say a few more. The data that we're collecting is being so at an international level and Canadian level, we have to do the same things. And so the data that we're collecting is on a common standard that was developed by the World Health Organization. And so all the way up, we're contributing those data to as high as the World Health Organization. We're pooling the data. So it's really important that we do that and create these platforms.
Right.
Then it's important that we link it. So thinking about big data. So now we have the outcome. Who is getting sick? What is their disease course? And what we really need to be able to know is identify those who do get sick and why, and do some of that electronic contact tracing. And to do that, we have to take these data that really were hard won from hospital systems and clinics and pool that and link it to the large population level data. So all of the public records for all individuals living in our province, which is equivalent to a US state, which includes all past hospital records, all information we know about where they live, their primary care physician, their local environment in terms of their socioeconomic status, their race and gender characteristics, new Canadians, really everything there is to know to basically reach across all the different data sets that we have on individuals in the province. And in this case, very safely be able to do analytics to help us understand who is being most affected by the disease in the general community.
Right. Yeah, and you know what? That's exactly what I was going to ask, was about how that scales up, kind of how that tracking scales up internationally, and how that affects the community. So that does actually kind of bring me a little bit around to there was a couple points there that you touched on that I was hoping that we could maybe quickly touch on before we get into some of these questions that we can start answering from some folks. But I'd like to go back and just touch on something that you mentioned about kind of the importance of distributed work teams, remote work teams, as we navigate this kind of thing. And then I'd also like to, flow into that. It seems like we were just kind of almost getting into that natural discussion about, the place where a lot of places are at right now, where we're looking at opening up and we're looking at how to do that safely. And there's a lot of unknowns there. So if that's
Yeah.
if it's not too much, maybe I'll just throw that all on your plate.
I guess remote work, anybody who's tackling this issue is having to do it remotely, which has, created new challenges. For those of us that work in the data sciences, like our group, it's been not too much of a challenge. We joke that we were sort of pandemic ready already because most of us connect through Zoom. We've got team members as far away as Vancouver, and then people that work for us as far away as, I think now probably the Canary Islands. One person anyway. And so we're used to meeting on Zoom, and it's sort of like a running joke on the team. Although I remember saying, like, as soon as they become a public company, we should definitely invest. But it's yet another trend that I've missed, even though I caught it early, which is why
Sure.
they say PhD is poor and hungry doctor. It's probably true. And so,
sure, yeah. So we missed investing in Zoom, and we missed. Yeah, go ahead. Sorry.
No, it hasn't stopped us. Is basically the jokes aside. And so, and people are working very hard on it. So I have chats with people in the Ministry of Health, at 10 o'clock at night on a Sunday, all kinds of wacky things, and all through, all kinds of products, for people to connect, and it works pretty well. But you mentioned about reopening, and the big challenge there is that, because things have been pretty stochastic in terms of like cases, what's been driving cases, and that we still have a huge amount of unknowns, mostly because so we know how to connect the data. We know we need to. We've been slow to do it. That would help us. It's increasingly getting better. But in most places throughout the world, there aren't the data structures and systems in place to respond to a rapidly evolving pandemic like COVID. And so that puts us behind the 8 ball, and we're in a situation in most places where we're opening up without having very good monitoring systems for cases. And so it's well known that we're generally not doing a good job around testing. And so, I mentioned before that we're collecting cases of individuals that are getting sick, and those we know, and we're capturing them, getting better at capturing them. All of their characteristics, their disease course, how well they do when they're discharged from the hospital. But we don't know the denominator. And what I mean by that is that we don't know those that are infected but don't develop symptoms. That's because we haven't built, in most places, the kind of contact tracing. We haven't had the capacity to do it, and testing that we need. And what would it look like? It's well known. People have mentioned it. We need to have an active approach to testing. Going to workplaces and doing a blitz of testing, going to places where people congregate and doing a blitz of testing to try and really discover and find out where the disease is and where it's hiding. If we had that information and a better sense of that information, we could develop better models to understand conversion into severe illness and where we're likely to see the most outbreaks. Right now, all we can tell is that those places that make a mistake and in unsafe ways, they're definitely at higher risk. We see that. And places where it's more difficult, high density areas like major urban centers, they're going to be the source of waves. And again, that's an example of COVID being highly localized. It's very likely that we'll see new cases in places in some cities where they've made mistakes or they've got a density that puts them at a disadvantage. And in other places, we just won't see it.
Yeah, it seems like it's on one hand, it's an interesting situation. On one hand, it's a troubling situation. And on the third hand, we really have to wait and see how things develop week by week. Well, hey, that's yeah, thanks so much for that comment. And actually, that does lead me into a question that we have from someone that's been watching. This is a question from Red Amancio. And the question is, based on the data, is it safe to reopen stores, schools, etc. in Canada by June? And I figured that kind of linked up to just what we were speaking about just now. What are your thoughts on that?
It's a big question, and no one knows, although there's going to be a lot of opinions. Mine's no better than anyone else's. They say it takes a lot of knowledge to realize, how uninformed or how ignorant you are. And so we've done a piece of work around COVID analytics, and based on that experience, I'd say it's very difficult to know, and we're kind of playing out an experiment because we don't have the natural advantage of a jurisdiction that's opened up, in and that we're able to understand what's happened from it. The part of the problem is that the incubation period of the disease is such that we will only see a spike in cases something like 3 or 4 weeks after there's been some serious moves towards opening up. And so we don't know until we or others try. And of course, there's tremendous economic pressure to open up behind it. So it's tenuous. The most important thing I think that we can do is prepare ourselves by bolstering our public health resources and our analytic capacity, so that our testing capacity, so that we can understand when maybe things are going awry sooner. And as we experiment with opening up, we get better and better at it, and we're able to look back on good examples and bad examples with evidence to be able to know that they were good examples or bad examples of opening up, and not just chance occurrences.
Right.
I'll give you, where we have an easier time. This is probably a good example to demonstrate where we have an easier time understanding spread characteristics is where things have gone out of control. So this strikes home for us. So for us, and our most important population and the most affected by COVID is older adults. And it's particularly true for people that are living in nursing homes. And so right from the start of this crisis, where did it really start in the United States? It started, the attention to it and the serious cases were around Washington nursing homes. And here in Canada, in the United States, I think nursing home or care home deaths account for about 40% of all COVID deaths. I believe that's the case. In Canada, it's more like 70% of all deaths. And that's been a tragedy, a total tragedy, because we were largely unprepared for it, and it's exposed a lot of problems in North America, and including Canada, around the system of long-term care and care homes. To demonstrate the point that we sort of need enough data to have an understanding. However, we know a lot about risk, and we're learning more and more because we have those outbreaks to learn from. And so it's sort of a sad example that we have so much information. But I'll give you an example. We recently worked with very hardworking folks in the Ministry of Health, working 7 days a week, 12 hours, to support some of their analytical capacity to look at what at a nursing home level is associated with risk of outbreak. And if there's an outbreak, the size of the outbreak according to the number of cases and the number of deaths. We have enough cases and enough examples to be able to do that and understand it, so far anyway, pretty conclusively. And we've learned some important things about how facilities are designed and how that influences risk, and how community spread, no matter how small, so community incidence, new cases in a community, how well that predicts an outbreak in the surrounding long-term care facilities. And if that occurs, how bad those will be according to the characteristics of each home. And that's been very important because right now we're in a state where we're using that information, our public health authorities are, to design targeting systems so that they can in advance know, depending on the scenario, which facilities are at greater risk, and so which ones they really need to focus on. Because we have about 632 in our province, and no place has the resources to have big interventions at all facilities. And so now we know which ones to target, and we know more and more day by day.
Yeah,
we don't quite know that at the community level. We just know that at the nursing home level because we've had such a bad outbreak.
Yeah, interesting. So I guess it's kind of, we unfortunately, it seems like a lot of the answers to this come back to, we need to see how it looks next week and the week after that and the week after that. So yeah, thanks so much, Andrew. I do have another question here, a really interesting question from Alex Ianovsky. And Alex asks, which remote health monitoring technology is the most promising for tracking and predicting health outcomes, and which might be the most overhyped? So let me, add to this. I'll add to this that, I'm not sure. I'm not sure actually. I'll just leave this to you. What are your thoughts on this?
It's still so new, the field of remote monitoring, and we're in a very infantile stage. And I don't think it's because the machines don't work. It's because the humans working the machines don't work. I'll give you an example. So the machines are efficient. It's the human beings that are less efficient. And there's also this constant problem of calibration. So
Right.
Humans are always the rate limiters, right? So your phone works faster than your brain does. And so you're the throttle. You're what's slowing down information from various sources being in your brain because you can't manage it. Now imagine a health system with fixed resources. There's only so many doctors, so many nurses, so many personal support workers, so many people to respond to other human beings in need. They're already busy, by the way. They can be
Right.
more efficient, that's certainly the case, but they're already working 40 or more hours a week. And if you asked all of them, they tell you that they're busy. Now input remote monitoring devices. And it sounds like it's a wonderful thing, and it is actually, that something that someone would have in their home would alert a healthcare provider or a health system or a hospital or a primary care group. The problem is that those events would have occurred and they would not have been alerted. And so it creates too many alerts, too many false positives, or even just true positives, that it overwhelms the system pretty quickly.
Interesting.
And so
So
here's a good example.
Yeah.
Let me give you an example. Like it's well known that people who have cardiac surgery, when they are discharged and they go home, they continue to have sort of like mini heart attacks. Some of them do, that are barely detectable. Now you can maybe create a device that detects, troponins, and will trigger a cardiologist. And that would be a very good thing, except there aren't enough cardiologists and people in their team to be able to respond to all those cases that they otherwise would not have known. So super important, but we're learning how to use them. A lot of them hold promise, particularly the ones that are easier to use. They hold the most promise. It's important to know that these systems need to be integrated, though. If they stand alone by themselves and they just do one purpose versus giving a suite of diagnostics, they're going to be a lot less used. The cost function is just so high to use them. So it's a great question. I don't have anything specific around particular devices, but there are many that are promising.
Brilliant. Okay, well, in that case, Francesca Mayajota has a question here about how do you deal with false information and numbers in the case the government doesn't post real numbers on one hand, and on the other, in the case when there is no real testing? Does that come through clearly?
Yeah, and it's so I'll tackle the last thing first. When there's no real testing, it's that problem that I mentioned, which is that we don't understand the underlying denominator. And so we don't know a true incidence rate. And that's why you get, if you're following the news, there's always a lot of suspicion and lack of knowledge around, what is the true death rate for COVID?
Right.
And what was it that we expected out of information from East Asia versus what it is today? And we still, amazingly, don't have a very good handle on it, because we don't know the true denominator of those infected. We only really are able to ascertain, and even always not perfectly, the numerator of those that are severely ill and those that die. And even that has a little bit of complications. So then you say, you
Right.
asked about untrustworthy data from sources around death rates. I'd say
Sure.
that they're difficult to capture. So how do you capture death rates? Usually it's still a manual process. There's no magic where you're able to, in a data streaming way, understand true death cases. Someone needs to manually interpret a death as a COVID death and enter it into a database that needs to be collated
Right.
and brought to a central location. And that's currently how it's done. And so it's a very human process still. It always will be. And because we're new at this process, the data isn't always perfect. I'll give you an
Mm.
example in where we've seen a lot of deaths in nursing homes and care facilities. That relies on reporting from the facilities uh, until such time as we have coroner's data and assessed data that happens usually sometime later. And the difficulty with those data is that when you look at count data, sometimes there can be errors or there can be double counting. What if somebody was transferred to a hospital and died there and not in the facility? Who's tracking that death? When they're tracking it, are they double counting it? Or are they failing to count it because the facility doesn't include it in the deaths that occurred in their facility? So that's an
Right.
example of nitty gritty that can sometimes lead to inaccuracies. But I'd say overall, rest assured, because from a data analytics standpoint, that's a little bit of noise in the data, but it's not something that changes the picture of what we're understanding. Our biggest problem is not knowing the numerator, excuse me, the denominator of cases, and not having
Right.
a good sense of how that works.
Right. Wow. Thank you so much for that. That was a great explanation. And so this actually leads me into a great question by Daniel Austin. And Daniel asks, what are practical things that you, Andrew, have changed in how you are behaving differently today, beyond the obvious of sheltering at home?
Yeah, I think I'm like a lot of people, a lot more aware of. Well, I cherish my social connections that much more. That's one thing, but I'm also a lot more cautious of them. You know, I have the experience where a lot of the work that I can do and always was can be a lot remote, and so I have no need like some people to head out every day in a vehicle and go to a place of work because my place of work can be a little bit almost anywhere. Obviously, I prefer it to be my university office with a team, but um, we can make do pretty well with what we've got. So for me, it's been uh, I mean, this is sort of trivial, but issues like not touching my face, although I probably touched it 10 times and I've chatted with you. You know, washing hands, which I was always pretty good about. I have family members that reinforce that. And when I do go and have to set out to do things like, you know, we're all doing more handy things around the house or trying to be handy around the house to the hardware store
Sure.
and so forth, very cautious about touching things and where I'm putting my hands and that I'm having hand sanitizer or washing them. Um, Masks are becoming more and more reinforced. And so to the extent that I think I'm going to be in closer proximity to people, I'll wear the mask. Where I'm very careful and where I implore people to be very careful is around people that they think are going to be at higher risk, like older adults. And so I
Mm.
interact a lot with my neighbors that are older adults, uh, actually very older adults, but you know, pretty spry for older adults. So I'm hoping it's something in the water in the neighborhood in our wells here. But I'm very cautious around them because they're a high risk group, and I would implore people to do the same. It's really important that you connect, but don't touch. And so phone calls to neighbors and families and conversations at very safe social distances are really important. But
Right.
be very wary. It's very easy, particularly when it's good weather, which we've just experienced in Canada from some folks connecting. Maybe you've always had it. Lucky you.
Mm.
You forget easy. So don't forget.
Fair enough. Great advice. Thank you so much. I have another question here from Ria Sen. And Ria asks, if you were in charge of public policy today, how would you approach the situation around balancing opening up the economy versus a more cautious approach?
Yeah, so you're getting beyond, things that researchers like myself love to comment about, but I'll venture a guess, and I'll bring it closer to home for myself. I think I proceed probably cautiously and in a phased manner, um, because it's important. We have no choice but to uh, start a little bit, and where we don't think that we're going to have a treatment right away or a vaccine right away, we have to, move safely. I think it's being accomplished in most places, and that's obvious because the projections didn't come true. And it's not because the projections were horribly flawed and we were fooled. That's not the case. It's because those were possible, and we acted to mitigate it. It was always going to be temporary, and we were always going to be stuck with this hard problem of opening back up and the need to open back up. It's really important that as societies, we place a lot of emphasis in our platforms to be able to track COVID, so that we know early and we can learn from mistakes and obviously detect mistakes sooner. So things that we haven't gotten around to, it's time to get around to with incredible speed. So we've always had the problem of not sharing data because of really important legislation, but also because people have just been unwilling to share information. That's really important that we do that now across all of our health systems, because one information source says nothing on its own. Together, it's exponentially valuable, particularly in this case.
Right.
And we have to get on this boring work that maybe some of you listening are aware of making our health information systems all speak a common language. Because,
Right.
as I said, we have a very local problem at a global scale. For us to understand anything, we have to be speaking the same language and have all of our systems aligned. And what I mean by that is, imagine the boring thing, which is you go to your physician and you see one, you see another, and the data is not following you. You keep getting asked the same questions over and over again. That's at an individual patient level. At a system level, that creates a big problem because we can't merge data because they're different data, differently structured data, and that causes a big problem. It makes this huge investment that we have in collecting some of these data almost useless because we've decided not to standardize some information sources.
Okay. Well, thank you for that. Yeah. In that case, I know that we're getting towards the 7:30 cutoff time, and I want to be, conscious of everybody's time. But I do have one more question here that's a pretty interesting one from Sarah Penn. And Sarah Penn asks, with the many restrictions and implications of social distancing, many concerns have been raised surrounding individual mental health. So specifically for primary caregivers that may no longer have the support they need or the ability to take a break from their role. Do you currently have any data on the rates of caregiver burnout? And if not, do you think COVID might impact these numbers? And can you talk about the availability of some resources moving forward when we're looking at, again, this is looking at mental health, primary caregivers, and informal caregivers and burnout.
Yeah, and so it's a really important problem and question, and it hopefully illustrates what I just said. And that is, there's no doubt that people are seeing anecdotally an uptick of people reaching mental health crisis, needs for support, for counseling services, etc. There's no question that's the case. Anecdotally, it's true. Because at all those different points of psychiatry, counseling clinics, psychiatric hospitals, we don't often collect similar data on patients that are receiving care. We collect different data that is kind of similar but can't be collated. We can't understand at a population level what the influence is. And when we can't understand it at a population level, then we can't control it at a population level. We can't understand it at a population level. And so where we have good systems that speak to each other, which are really important clinically from provider to provider, we can actually utilize those systems to understand group phenomenon and population level phenomenon to help us target resources. So in this case, we're a little bit behind, and there's no doubt there's an absolute ton of need out there.
Wow. Yeah, thank you. And I know I said that was the last one, but I actually do have another question here from Campbell 190 from Sam Siassi.
Is that you?
On Twitter. No, that's not me. I do have a question for you. I'm going to save it. I'm going to save it until after this because it's it's the big show one. So here's a question from a friend, Sam Siassi. Has the question been asked about cover testings and why there's so many false negatives? And about maybe antibody testings and effectiveness in comparison?
Yeah, it's a great question, and you have me at a disadvantage. I have colleagues that look at that question in particular. All I will tell you from secondhand knowledge, because I'm not an infectious disease expert, is that respiratory illness is very difficult to detect, and it's very difficult to test for. And that has to do with two things. Number one, the manner in which we typically test it with swabs, et cetera, are very sensitive to the quality of the sample that you get, which has led to practices where for people to be declared negative, you need to have 2 successive negative tests, for instance.
Right.
And also just the way in which viral load is retained in a system varies between respiratory illnesses, and it's very difficult to understand from a test where you are in the trajectory of disease and symptoms. Right. That's the best I can do in answering your question. And I'm aware of some of that debate, but I'm not knowledgeable enough to give you a solid answer.
Fair enough. Hey, that's no problem. Well, in that case, I just have one more question. And it's one from myself to you, Andrew. And it's, what do you think this means for the future dress code of academics? Because I'm concerned that we'll never wear khakis again. I think this might be a sweatpants situation that we're going to take back to the office. Can you comment on that?
All I know is it's meant that we don't have to iron our shirts to be on Zooms. It just needs to be more or less ironed out, or not too horrible, this side up. Below it doesn't matter. The state of academic dress in academia was always so low that this has just got to be an improvement.
All right. Well, that's beautiful. On that note, in that case, what I'm going to do then, I'm going to extend a big thank you to Nabil again for inviting both myself and Andrew on to come and chat today. And I'd also like to turn it over, Andrew, just in case you have anything, any last remarks that you'd like to wrap things up with.
No, thanks, Graham, for the discussion, and thanks, Terminal, for inviting us. This was fun. Hopefully, informative for those that were listening. Be safe.
Yeah, that's fantastic. I had a lot of fun. So stay safe, and I think on that note, then let's pass it back over to Nabil. So thanks again, Nabil, for having us, and yeah, stay safe out there.
Thank you, Graham, and thank you, Dr. Costa. So we are thrilled to bring the Terminal Tech Talk series to you every single month. And next month, we have another amazing speaker in Alex Lazaro, who recently published a book called Out Innovate: How Global Entrepreneurs Are Rewriting the Rules of Silicon Valley. That one will be moderated by Terminal's very own Clay Kellogg, and I will share more details with everybody who registered after the broadcast. But with that, it's a wrap. And I want to thank Eric for managing everything so smoothly on the live stream. Thanks, Eric. And thanks, everyone, for joining. We'll see you next month.